Hello, everybody. I am Sripad, a consultant legal and financial planning professional from Sriyan Envisions. Today, Dr. Anil Sangli shall speak about the neurological problems and complications secondary to coronavirus. He shall also touch upon various strategies for neurosurgical professionals to get back to their surgeries. This talk is strictly for medical professionals. Welcome, Dr. Anil.
Good evening, ladies and gentlemen. I am Dr. Anil Sangli, consultant neuro and spine surgeon from Sriyan Envisions. Today, I would like to discuss about the neurological implications of the coronavirus, which is a part 2. I had already discussed about this earlier during the early phase of corona, but I would like to add a few things which are over a period of time found by various types of investigating authorities and which has been reported in various journals all over. As we all know, coronavirus is a devastating respiratory illness that has dramatically changed everybody's life. And I don't think in the near future all the doctors, especially the neurologists, the neurosurgeons, anybody in any field will be able to get back to the normal routine like in the pre-corona days. There has been an unparalleled increase in the number of cases globally. But this pathogen, the coronavirus 2, was thought to be an acute respiratory infective virus. Since the disease has spread to most of the countries, it has already been recognized as a pandemic, which was declared by the World Health Organization on 11th March 2020. As we all know, the respiratory symptoms are the predominant ones like dry cough, dyspnea, that is difficulty in breathing, severe fatigue, and fever. Fever may be in the range of between 100 to 100.1 or 100.5 degree Fahrenheit. The neurological manifestations most commonly found in several studies world over are headache in about 10 to 13% of the patients. Patients can come with dizziness in about 8 to 15%. They can have an altered level of consciousness in about 8 to 9%. And as we all know, there can be a decrease in the sense of smell and decrease in the sense of taste sensations, along with various types of neuralgias. It may be in the upper limb, lower limb, or it sometimes can be involving the cranial nerves also. About 3 to 4% of the patients can come with acute cerebrovascular events. It can be in the form of a stroke or it can be in the form of a bleed. And about 1 to 2% of the patients can come with epilepsy and post-cerebellar signs like ataxia. And cerebrovascular disease can be a poor outcome risk factor in these patients. And also patients who already have had a prior cerebrovascular event or have hypertension, diabetes, especially poorly controlled diabetes, and patients who are having coronary artery disease can be poor candidates if they develop neurological manifestations. The virus is the actual strand of the RNA which attaches itself to the respiratory system. This SARS coronavirus 2 is a single-stranded RNA virus which envelops itself along with an amino acid sequence, and this causes acute respiratory syndrome similar to SARS coronavirus type 1 also. This virus is believed to be using the angiotensin converting enzyme 2, that is the ACE2 receptor, for its cellular adherence in the respiratory epithelium. There has been ACE2 receptors in the respiratory tract and in the gastrointestinal tract, and that is the reason why this virus is easily attaches itself to the respiratory as well as the gastrointestinal epithelium. This receptor attachment to the brain is very interesting. The actual number of ACE2 receptors in the brain are very low, and it has been found the ACE2 receptors are present in the epithelial or the endothelial cells in the central nervous system. But the number of receptors in the brain, since they are low, the postulate as to how it can enter the brain and enter the cerebrospinal fluid is an enigma. There are various postulates, various theories as to how this has entered into the central nervous system. It can be either because of an endothelial adherence as a route for the central nervous system infiltration. It can go through the transsynaptic viral pathways, after it can have an initial peripheral neural invasion. There has been an increased prevalence of the SARS coronavirus in the cerebrum, especially in the glial cells, because the number of ACE2 receptors in the glial cells compared to other parts of the brain like the cerebellum are a little less. So, and the other way of telling is the ACE2 receptors may be present in the glial cells, which was not known until now. Since the coronavirus gets attracted to the ACE2 receptors, it has been postulated that the number of ACE2 receptors in the cerebrum, especially in the white matter, is more, and that is the reason why it can enter into the cerebrum. In the brain, at least there are about 3 cases reported till I have read this journal in patients who present themselves with features of encephalitis. And the first case was actually in Beijing Hospital, where they actually demonstrated a virus in the cerebrospinal fluid. Patients can also present with severe sinusitis, which complicates itself and then involves the medial part of the temporal lobe with associated encephalitis, and they can later on end up with ventriculitis. And also, certain types of hemorrhagic necrotizing encephalopathy features are found, wherein the medial temporal lobes and the thalami bilaterally, which is a symmetrical involvement, can be seen in these patients. It has been very well demonstrated in the MR. The neurological invasion can be a direct invasion into the brain, or it can enter through a blood circulation pathway. It can also be through a direct neuronal pathway, or sometimes they postulate that it could be because of a hypoxic injury. The immunological injury and the cytokine storm which happens because of this acute immunological reaction secondary to the cytokine storm by infection with coronavirus can also cause vasodilatation, breakage of the blood-brain barrier, and the invasion of the viruses from the bloodstream into the central nervous system. And ACE2 receptor expression in the brain, which was not known hitherto, probably is also responsible for direct infection. It's also been seen that there's a direct seeding and a transsynaptic infiltration through the olfactory nerve, that is a perineuronal spread, which I had alluded to earlier in the previous talk. In the brain, it can directly enter through the olfactory nerves or from the oral cavity, especially near the region of the tonsils. There can be an increase in the concentration of the viral particles, wherein it can enter from the oral cavity into the lingual nerves, and subsequently there can be a rapid spread into the medial brain structures, especially the medial temporal lobe, and affinity for the medial temporal lobe, basal ganglia and thalamus and the midbrain in the sequence is not known. There has been a lot of long-term effects in coronavirus, and the patients who have recovered from these neurological problems may have some psychological effects secondary to this as a sequence of an anxiety and a depressive type of a disorder, or whether they go in for a long-term neurodegenerative pathology or a problem is yet to be seen. The patients need to be screened, throat swabbed, a chest CT done in almost all the patients if they come with a particular type of infection suspected of a coronavirus, and the OPDs in which the patients are seen must be sterilized, preferably twice or thrice daily, and the anesthetic pre-operative consultation must be taken, especially if they are planned for any elective or semi-emergent type of procedures. Now, when you go in to perform an operation in a patient for with this type of a problem, these operations have to be performed with a very clear-cut guidelines. The operation room should have negative pressure suctions, and the operation team should be optimized for this particular procedure. The duration of operation should be very less, let's say less than an hour or so. And as far as possible, in neurological procedures, when you do this bone drilling, the spread of bone dust and the aerosolization of the particles during drilling can cause infection. And the anesthetic circuit which is being used must be a closed circuit with a negative suction, so that the anesthetic gases are not exposed on to the environment where the surgeon operates. And more often it is pertinent that the surgeon enters the OT at least about 20 minutes after the patient is intubated. The anesthetist first enters into the OT, intubates the patient with all precautions, puts all the central lines and all the catheters and other things which are necessary in the OT. And after about 20 minutes of these procedures are being done, the surgeon and his team should enter, and the procedure, as far as possible, should be completed within about an hour or an hour and a half. And the patient must be shifted directly from the OT into the ward or into the COVID ICU if the patient is COVID positive, or if the patient is suspected to be COVID and still you do not have the reports, he should be in a separate ICU. It is mandatory for us to have proper COVID ICUs and an ICU which you have a suspicion where patients may be COVID till the results are awaited, and in and in the normal general ICU where the patients are being kept. So it is mandatory for us to keep these patients in separate units so that the infection from the patients to the doctors or the nursing staff is prevented, or there is an inter-patient infection from a non-COVID patient to a COVID patient, or from a COVID patient to a non-COVID patient. Suppose if the non-COVID patient is a carrier, these precautions are mandatory. The emergencies, electives, whether it is a cranial emergency or a spinal emergency, must be prioritized by the neurosurgical facility or by the neurosurgeon. Ideally, if a few hospitals come together in this type of a scenario, certain hospitals can take up the cranial work, certain hospitals can take up the spinal work, and certain hospitals can take only emergency work or semi-emergency work, and electives can be allotted to certain type group of hospitals. So it is good if the private and public sector hospitals have a combined effort so that the patients are prioritized to whether they are emergent or semi-emergent or elective, and then they can be categorized and operated depending on their level of priority. If the patient has got a level of consciousness which is worsening, then immediate surgery is mandatory. If he has got a mass effect or he's got a midline shift and the patient is deteriorating and which can be salvaged with medical measures, then about a day or two can be taken so that the patient can be prioritized and accommodated into a particular category where he can be operated. If the patient does not have any mass effect, or if it's a tumor which can probably stay for a month or so, then it is ideal till all the cases in that particular vicinity become negative, the number of cases come down in the vicinity, and the graph of the number of COVID positive cases reduce in the place of work so that they can be taken as an elective case without much risk for infection of the patient himself or for infection of the doctor and the healthcare workers. It is important to educate the health professionals and the public, especially the nursing staff and the people at the hospital, about all these measures and all the measures where they have to know about the emergent and the semi-emergent conditions so that proper precautions and prioritization can be taken. The screening of the cases is very, very important, and it is important to have different waiting rooms, especially in the outpatients, where patients who are actually symptomatic with COVID have to be kept in a separate place with a fever clinic and directed to another OPD. Asymptomatic doubtful cases must be in a separate group, and asymptomatic non-suspected cases must be in another group, so that there should not be cross infection between asymptomatic carriers to asymptomatic non-carriers. And if the patient comes with severe nerve root compressions, any spinal cord injuries or nerve dysfunction, spinal fractures, acute traumas with head injury or spinal injury, if there is a displacement of bone structure, or if there is a large clot with mass effect or midline shift, then whether the patient is COVID positive or negative, the patient has to be taken as an emergency, and all patients especially in emergencies, must be treated as COVID positive and then taken up for surgery with all due precautions, just like how it is being taken for a patient if he is COVID positive. As far as possible, minimally invasive surgery must be utilized, and the utilization of the scope and the sterilization of the scopes, if it is being used, must be done with proper due precautions. And as far as possible, a prone position or a lateral position is ideal, especially in patients with spinal surgeries. When the aerosolizing risk is present, especially with the use of suction and cautery in neurosurgical procedures, it is mandatory to avoid splatter of the liquid into the operative field. There are some suctions available wherein as soon as the aerosols are produced, it is sucked up, or if there is a vapor that is coming out secondary to a monopolar or bipolar artery, the suction has to be used immediately so that the smoke does not disseminate, because the smoke itself can carry the virus and can cause an infection even though the surgeon and the health staff are using N95 masks. The spine procedures can be divided depending on whether it is a cervical or a thoracic myelopathy or an acute trauma, or patients having an epidural abscess or a cauda equina syndrome, severe nerve root compressions. They can be taken up as an emergency. In level 2, the patients or a semi-emergency, patients with an acute or subacute lumbar disc herniations or severe radiculopathy, severe pain, features of sensory and motor neuropathy, all these things can be taken as a semi-emergency. And the patients having degenerative problems like scoliosis or lumbar degenerative stenosis, patients having a long duration kyphosis or axial type of back pains, these patients can be taken up as a elective once the emergent condition is reduced. So summarizing the whole talk, pre-existing cerebrovascular disease can be a risk factor, poor outcome group in patients who are infected with COVID. Patients with COVID infection can come with headache, dizziness, anosmia, hypogeusia, decreased level of consciousness with acute cerebrovascular events, seizures, and with ataxia. The mechanism of invasion of this virus, though it is not fully understood, appears to be having a neuroinvasive potential, can cause viral encephalitis, can cause hemorrhagic necrosis, involve the mesial brain structures, the temporal lobes, and the thalami more often. And the neurodegenerative effects of coronavirus have to be elucidated on a long duration or a long term uh, studies. The neurological and neurosurgical practice patterns have to be changed, and especially the neurosurgical practice and the inpatient, outpatient, and the ICU or critical care setups have to be made in such a way that the patients, the doctors, and the health staff are not prone for more infection, and there is a chance that all of them can have and work amicably so that none of them get infected and the patients also get treated at the same time. It is important to prevent the cytokine cascade and an increased risk of cerebral hemorrhage, especially in patients who have coronavirus in the lung as well as in the brain. It has been reported that this cytokine storm syndrome can be one of the major factors which can cause an acute cerebrovascular disease. And so we have to keep a watch on the D dimer levels and a platelet reduction so that it can cause a DIC-like picture, which has to be kept in mind, especially in the patients who have this neurological problems. So it is not only a respiratory involvement, it is an involvement with an increased concentration of the viruses in specific areas of the brain, in specific type of cranial nerves, in the central nervous system. And it has also been found in autopsy studies that these viruses have an increased affinity to the heart, the cardiac tissues, to the kidneys and the liver. But though they are not the cause of death in those patients, it has been basically the respiratory involvement and hypoxia with the cytokine storm which has killed them. It has also been found that the increased concentration of viruses in the tissues also are seen. General surgeons also must be aware that the peritoneal fluid also can cause this, and the fumes that arise out of monopolar cautery can have these viruses, and so it is mandatory that they have a triple mask and take all precautions. Thank you very much for your kind listening. Please give your comments below.